Good afternoon. My topic of presentation is a case report of orbital emphysema. Purpose: to report a classical case of orbital emphysema. Introduction: orbital emphysema is typically a benign condition that occurs following forceful injection of air into the orbital soft tissue spaces. In many cases, there is a history of trauma and fracture of an orbital bone which permits air entry. Case report: an 18-year-old male patient reported to ophthalmology department with complaints of chemosis of right eye following trauma. Severe chemosis of right eye associated with right frontal bone fracture is present. Mild restriction of ocular movements of right eye is present. This is a patient showing right eye chemosis and right eye frontal bone fracture is present in CT. Discussion: with orbital emphysema, there may be complications with a range of severity, including proptosis, loss of vision, increased intraocular pressure, and more severe complications caused by an orbital compartment syndrome. CT is effective in identifying the presence and anatomical location of an air when orbital emphysema is suspected. Conclusion: management of orbital emphysema depends largely on clinical presentation and imaging findings. If there is a suspicion of orbital compartment syndrome, emergency decompression is done by needle aspiration of trapped air. In other cases, orbital emphysema will resolve on its own. Thank you.
Good evening. My topic of presentation is Marcus-Gunn-Joe-Winking syndrome in a patient of congenital ptosis. Introduction: this syndrome is seen in 5% of all congenital ptosis. Most are unilateral, and it has been postulated that a branch of mandibular division of the fifth cranial nerve is misdirected to the levator muscle. Case report: a 9-year-old male child presented with drooping of left upper lid and complaints of involuntary lid elevation on eating food. Child born via normal vaginal delivery, full-term baby, developmental milestones achieved up to age. On general examination, brow position, facial symmetry were normal. Head symmetry, slight chin elevation was noted. On ocular examination, on the upper lid of the left eye, there was drooping noted. Other anterior segment findings were normal. Fundus was within normal limits. On ptosis evaluation, the uncorrected visual acuity was both eyes 6/6. Extraocular movements were full in all direction. Palpebral fissure height was 10 mm on the right eye and 7 mm on the left eye. Palpebral fissure on down gaze was 2 mm on right eye and 4 mm on the left eye. MRD1 was noted to be 4 mm on the right and 1 mm on the left. MRD2 6 mm on both eyes. The LPS action 15 mm on the right eye and 9 mm on the left eye. No lag ophthalmos was noted. Lid folds were present. Lid creases were 7 mm in both eyes. The amount of ptosis from the difference of palpebral fissure values were 3 mm and from the difference of MRD1 was 3 mm. Bell's phenomenon was noted good in both eyes. And there was elevation of ptotic lid was seen on mouth opening, jaw movement to contralateral side, and jaw forward protrusion, which was seen on the left side of the ptotic lid, and not seen on clenching of the jaw. Grade of the ptosis on elevation of the lid was 6 mm. Corneal sensation were present in both eyes. The diagnosis is a left complex moderate congenital ptosis with good LPS action and severe Marcus-Gunn-Joe-Winking phenomenon. Management: unilateral levator recession to address the synkinetic winking component with ipsilateral frontalis suspension for lid elevation solely to the frontalis muscle elevation. Thus, he was referred to higher center in view of his surgical management. Discussion of the topic: etiopathogenesis is unclear, most commonly due to any congenital aberrant connection, trauma, or eye surgery. Most patients, they learn to mask this phenomenon. 6-monthly follow-up is advocated. Photographs help in monitoring of the patient. The necessity for correction is determined by the parent, patient, and surgeon depending on any severity. And any amblyopia and strabismus should be addressed. Thank you.
Good afternoon, everyone. I'm Nandini Vedashri, second year postgraduate from MIMS. I'm going to present IgG4 related orbital disease, a case study. A 48-year-old female with known history of diabetes and hypothyroidism on medication presented with left eye protrusion, upper lid drooping, which is insidious in onset and gradually progressing since 4 months and associated with pain and redness. She used antibiotics and steroids, but symptoms were not relieved. Past surgeries, she has underwent hysterectomy, appendicectomy, and excision of mass from the back of the neck due to tubercular granuloma. On ocular examination, non-pulsatile eccentric proptosis of the left eye and drooping of the left upper lid and was seen, and restricted ocular motility was present. On palpation, firm tender mass in the supralateral region of the orbit was felt. Laboratory findings: complete blood picture, ESR and thyroid profile was done. ESR was shown slightly raised values and thyroid profile within normal limits. Radiological findings: on CT scan, axial section heterogeneously enhancing lobulated mass in the anterior part of the extracorneal space was seen with size 3.2 into 2 into 1.6 centimeters. On coronal section, mass at the supralateral aspect of the anterior orbit was seen. Management: as the patient was non-responsive to the antibiotics and steroids, left eye anterior orbitotomy was performed, mass excised and sent for histopathological examination. Histopathology: granulomatous lesion with fibrinoid necrosis and inflammatory lymphoplasmacytic infiltrate was seen with end arthritis obliterans. Hyalinizing fibrosis was seen with query IgG related orbital disease. So the final diagnosis, IgG4 related orbital disease, was confirmed by elevated IgG levels and with immunohistochemistry, where IgG4 positive plasma cells were seen up to 15 per high power field, and IgG4 is to IgG ratio positive plasmas with plasma cells 48%. Discussion: immunoglobulin IgG4 related orbital disease is increasingly recognized syndrome of unknown etiology, most common in middle-aged and older men, comprised of the collection of disorders that share specific pathology, serological and clinical features. Hallmark of IgG4 related disease are lymphoplasmacytic tissue infiltration of mainly IgG4 positive plasma cells accompanied by fibrosis and obliterative phlebitis, often present with subacute or diffuse enlargement of affected region. Lymphadenopathy is common and symptoms of asthma and allergy may be present. Diagnosis of IgG4 related disease is based upon biopsy findings demonstrating the characteristic histopathology. Serum IgG4 levels should be measured, and isolated elevated levels is significant and which aids in diagnosis. So several manifestations typically occur in the same patient and previously thought to be unrelated and include are type 1 autoimmune pancreatitis, Mikulicz disease and orbital pseudotumor and dacroadenitis, idiopathic retroperitoneal fibrosis, chronic sclerosing aortitis and periaortitis, radial thyroiditis and a subset of Hashimoto's thyroiditis, IgG4 related pulmonary inflammatory pseudotumors, IgG4 related renal disease, particularly tubointerstitial nephritis. Thank you.
Good evening, I'm Dr. Monica. My poster is Atypical Orbital Apex Syndrome secondary to intracranial suprasellar mass lesion, a rare case report. Orbital apex is anatomically a posterior part of orbit where orbital valves converge. The orbital apex incorporates optic canal, superior orbital fissure containing optic nerve, and all the structures passing through the superior orbital fissure, 346 nerves, etc. Various etiological factors like inflammatory, infectious, neoplastic, traumatic, vascular causes can also involve orbital apex, leading to orbital apex syndrome. Atypical orbital apex syndrome is one which presents with individual cranianopalsis, bilateral optic nerve involvement due to anterior chiasm lesion. Case report: a young female 29 years presented with drooping of upper eyelid since 3 months, defective vision since 4 months and headache since 3 years with restricted ocular movements except abduction in left eye. On examination, left eye exotropia 15 degrees Limitation of adduction, elevation, depression, dextro elevation and dextro depression is present. Right eye normal ocular movements. On examination, right eye visual acuity is 612 with pinhole no improvement. Other anterior segment findings are within normal limits. Left eye visual acuity PL plus PR present in all quadrants with moderate ptosis and pupil mid dilated and fixed. Remaining anterior segment findings are within normal limits. Ptosis examination left eye MRD1 is 2 mm, MRD2 is 5 mm, palpebral fissure height is 7 mm. Bell's phenomenon is absent. Fatigability test and ice pack test were negative. Fundus examination right eye media is clear. Optic disc temporal pallor present, margins well defined, cup disc ratio is 0.3:1, vessels normal, macula FR plus and peripheral retina is normal. Left eye media is clear, optic disc diffuse pallor present, margins well defined, cup disc ratio 0.3:1, vessels normal, macula FR plus and peripheral retina is normal. On visual field analysis 30-2, visual vertical defect is seen in right eye. MRI brain and orbits shows well-defined T1, T2 heterogeneous hyperintense solid cystic mass in suprasellar region with hemorrhagic component within it, suggestive of craniopharyngioma or germinoma. Clinical diagnosis, atypical orbital apex syndrome presenting as oculomotor palsy, left eye with bilateral optic atrophy, secondary to intracranial suprasellar mass lesion. Discussion, atypical orbital apex syndrome presents with involvement of any of the cranial nerves passing through the superior orbital fissure and optic nerve. Extension intracranially presents with atypical features like involvement of anterior chiasm presenting as bilateral optic atrophy. In this case, the patient presented with severe loss of vision in left eye with third nerve palsy and bilateral optic atrophy, sparing fourth and sixth cranial nerves. It leads to atypical presentation of orbital apex syndrome. Conclusion, this case highlights the importance of evaluation of oculomotor palsies with fundus examination and neuroimaging, which reveals mass lesions involving the anterior chiasm, which is challenging for neurosurgical management. Early diagnosis of atypical orbital apex syndrome and proper management by ophthalmologist and neurosurgeon will help to save the patient going into total optic atrophy and management of other complications secondary to intracranial mass lesion. Thank you.
Good evening everyone. My name is Dr. K. Manjula. Today my topic is pyogenic granuloma of lower eyelid. Aim to study and outline the management of pyogenic granuloma. Background, pyogenic granuloma is a benign lesion that occurs in the skin and mucous membrane as inflammatory hyperplasia. It is a focal reactive growth of fibrovascular or granulation tissue with extensive endothelial proliferation. It present as a sessile or pedunculated lesion with a smooth or lobulated surface. It is erythematous, bleeds easily untouched, and it is non-tender on palpation. Case details, a 50-year-old female patient from Rayachoti, Kadapa was referred to ophthalmology OPD with mass on medial aspect of left eye lower lid for the past 1 month, which started as a small blister-like lesion, gradually increased in size and attained the present state. History of bleeding with trivial injury. History of minor trauma to lower lid was present 1 month ago with goat horn. The patient's medical history was unremarkable. There was no history of any surgeries to the lower lid in the past. General examination was normal. No regional lymphadenopathy was found. On local examination, a sessile lobulated pinkish red mass of about 5 into 5 centimeters was seen on the medial 1/3 of the lower eyelid of left eye, extending onto the medial canthus. Surface is lobulated, grayish white membrane seen on the surface, soft, non-tender, irreducible, no thrill is felt on the mass and not increasing in size with Valsalva maneuver. On ocular examination, anterior segment was normal, posterior segment evaluation was normal in both eyes. Best corrected visual acuity was 6/6 in both eyes. Her blood pressure was 120/80 mm of Hg and all other routine blood investigations were normal. On histopathological examination, it reveals a polypoidal lesion covered by non-keratinized stratified squamous epithelium with irregular acanthosis, extensive ulceration and underlying inflamed granulation tissue. The underlying stroma was edematous with foci of lymphoplasmocystic inflammatory cell infiltrate. There was diffuse proliferation of dilated, thin-walled and congested vascular spaces in the stroma. The blood vessels were lined by a single layer of bland endothelial cells. Patient was kept on oral beta blockers, oral propranolol 0.5 milligrams per kg body weight in 3 divided doses a day for about 4 weeks, following which the mass has drastically reduced in its size and vascularity. And surgical management, radical excision of the mass followed by reconstruction of the defect done by transposition flaps under local anesthesia. Intraoperative bleeding was secured. Postoperative period was uneventful. Postoperatively, broad spectrum antibiotics and NSAIDs were given. Sutures were removed on 7th postoperative day. Thank you.
I'm Dr. Malati. Today I am presenting a rare case report of juvenile ocular myasthenia gravis associated with type 1 diabetes mellitus and hypothyroidism. Introduction: myasthenia gravis is autoimmune disorder caused by antibody mediated blockade of neuromuscular transmission that causes skeletal muscle fatigability and weakness. Autoimmune attack impairs the function of nicotinic postsynaptic acetylcholine receptors on the motor end plate. Myasthenia gravis, it can be generalized or localized, as ocular myasthenia gravis affects the extraocular muscles, LPS and Muller's muscle. Ocular myasthenia gravis presents before 19 years is termed as a juvenile, which is a rare condition. Type 1 diabetes mellitus, it can be accompanied by other autoimmune diseases such as thyroid disease and juvenile ocular myasthenia gravis. A human leukocyte antigen locus is the strongest association with autoimmune disorder, including juvenile ocular myasthenia gravis. Case report: a 17-year-old boy presented with 2 months history of drooping of eyelid both eyes since 2 months, increasing in the evening and improves in the morning. Horizontal diplopia since 1 month. Restricted extraocular movements since 1 month. Ocular examination: left eye is in exotropic. Lids, right eye moderate ptosis, left eye mild ptosis, frontalis overaction present in both eyes. Sleep test, Kogan-Littwitz test, IcePack test reveals positive in both eyes. Pupils, both eyes regular, round, regular, reacting to light. Lens, both eyes clear. Fundus, both eyes within normal limits. Extraocular movements, right eye limitation of adduction and left eye limitation of abduction is present. He is a known case of type 1 diabetes mellitus on insulin therapy since 5 years, and known case of hypothyroidism and treatment of tablet thyroxine since 1 year. Discussion: ocular myasthenia gravis is a rare disease in pediatric population and should be considered as a differential diagnosis in cases of ptosis. Clinical assessment including sleep test, Kogan-Littwitz test, IcePack test are positive. Acetylcholine receptor antibody is 2.49, which is positive, and pharmacological tests like hydrophonium test, neostigmin test, RNS and single fiber EMG tests are important, making the diagnosis and management of ocular myasthenia gravis. The patient was managed medically at higher centers with tablet Graviter 60 mg QID. Conclusion: ocular myasthenia gravis is a progress to generalized myasthenia, so regular follow-up is required. It is important for clinician to be aware of these combinations and possibility of the association between various autoimmune disorders in order to improve the disease outcomes. Thank you.
Good evening everyone. My name is Priyanka, a second year postgraduate. Now I am going to tell a case report regarding a case of ocular myasthenia gravis. A case report: a 65-year-old female named Kotamma came with a chief complaint of drooping of both the eyelids with generalized weakness since 2 years, more since 3 months, relieved in air-conditioned room, and defective vision since 6 months in both the eyes. On local examination, face shows bilateral ptosis and chin is elevated. Extraocular movements of the both eyes shows partial restriction of all the movements of -3 grade. And coming to the right eye, visual acuity unaided is 636 and with pinhole no improvement found, and near vision is N36. Eyebrows position is normal, eyelid shows complete ptosis. Lid crease is present and lid position MRD 1, 2, 3 are -3, 5 and -2 respectively. And LPS function is poor with 3 mm. Eye SPAC test after which MRD1 was done and which shows 3 mm, that is a 6 mm variation is noted. Extraocular movements also shows an improvement from -3 to -1. And interpalpebral fissure vertical is 0 mm and lens shows grayish white. Fundus shows grade 1 hypertensive retinopathy. Coming to the left eye, unaided visual acuity is 636 with pinhole no improvement found, and near vision is N36, and eyebrows position shows mild brow elevation. Eyelids shows severe ptosis, lid crease is also present, and lid position MRD 1, 2, 3 are -4, 5 and -2 respectively. LPS function is poor with 3 mm. After the eye SPAC, MRD1 was done and which shows 1 mm. That is a 5 mm variation is noted. Extraocular movements also shows an improvement from -3 to -1. Interpalpebral fissure vertical diameter is 1 mm and the lens shows grayish white, and fundus is grade 1 hypertensive retinopathy. Ptosis examination of the patient showing before and after the eye SPAC test. Investigations and diagnosis include applanation tonometry, both the eyes 18 mm Hg at 2 p.m. and nerve conduction study and repetitive nerve stimulation study suggestive of sensory motor axonal neuropathy and decremental response respectively. Acetylcholine antibodies are 36 nanomoles per liter. Normally the positive value is more than 0.5. HRCT test is suggestive of thymoma, and diagnosis is ocular myasthenia gravis with IMSC with grade 1 hypertensive retinopathy. Patient was referred to the neurology and advised tablet pyridostigmine 60 mg TID after the food. And discussion, myasthenia is a reversible autoimmune condition that destroys the acetylcholine receptors at the neuromuscular junction, leading to the decreased muscle activity. Hence, early diagnosis can help the patient to improve the quality of the life. Thank you.
Good evening to one and all. I am Dr. Pallavi. The topic of my presentation is an acute presentation of thyroid eye disease in a male with euthyroid state. Thyroid eye disease is a complex orbital inflammatory disease which is sight-threatening, debilitating and disfiguring. TED is also known as Graves' ophthalmopathy, named after Robert J. Graves, an Irish physician who first described thyrotoxicosis in a woman presenting with goiter, rapid heartbeat and exophthalmos. The overwhelming majority of TED cases are associated with hyperthyroidism, while the rest are euthyroid or hypothyroid. Risk factors for the disease include female gender, middle age. Smoking is the strongest modifiable risk factor for developing thyroid-associated ophthalmopathy. The signs and symptoms of thyroid-associated ophthalmopathy are varied as its epidemiology and pathophysiology. Symptoms range from watering, eye pain to double vision, and signs extend from conjunctival injection and chemosis to lid retraction, EOM restriction, strabismus, to sight-threatening exposure keratopathy and compressive optic neuropathy. Diagnosis is based on series of investigations including blood levels of thyroid hormones, MRI brain including orbits, enhanced CT brain that shows extraocular muscle enlargement. Treatment is symptomatic in acute phase, and other modalities like orbital decompression as and when required. The case report is a 25-year-old male presented with complaints of swelling of both eyes, pain, photophobia and watering since 3 days. There was no complaints of diplopia. The patient did not give any history of fever or any trauma. There were no similar complaints in the past, no similar complaints in the family as well. He's a chronic smoker since 8 years. On examination, the visual acuity was 6/6 in both eyes. Bilateral mild proptosis with upper lid retraction was noted. Extraocular muscles showed movement restriction, more in infraversion, supraversion and adduction. On slit lamp biomicroscopy, anterior segment showed severe congestion and chemosis of conjunctiva in both eyes. Rest of the ocular and systemic examinations were within normal limits. The investigations are as follows. The picture of the patient shows severe chemosis, conjunctival injection, upper lid retraction and mild proptosis of both eyes. This is the MRI section. The term thyroid eye disease denotes typical ocular changes which include lid retraction, lid lag, and proptosis. These changes have also been labeled as endocrine exophthalmos, malignant exophthalmos, dysthyroid ophthalmopathy, ocular Graves' disease, Graves' ophthalmopathy, and thyroid-associated ophthalmopathy. There are various classifications for the same. The diagnostic criteria of TED include combinations of the classical signs, which include eyelid retraction to the level of superior limbus or above along with any of these, thyroid abnormalities, preferably including anti-thyroid antibodies, exophthalmos, optic neuropathy, extraocular muscle involvement, or thyroid function abnormality with one of the following, that is exophthalmos, optic neuropathy, extraocular muscle involvement. The treatment for TED should be multidisciplinary approach involving an ophthalmologist, endocrinologist, a radiologist, and a general physician. The principal aim should be thyroid function control, as this is associated with reduction in the severity of the disease. Systemic corticosteroids are considered and are most effective in this phase. In our case, we administered intravenous methylprednisolone for 3 days, followed by tapering dose of oral prednisolone for a period of 3 weeks. Other agents like cyclosporine, azathioprine, rituximab are gaining popularity and are under clinical trials. Coming to the conclusion, thyroid-associated orbitopathy is a debilitating and vision-threatening disease. Pathophysiology of the disease is yet to be completely elucidated. However, thyroid-associated ophthalmopathy is understood to be an inflammatory process. Activation of pro-inflammatory cytokines results in increased hyaluronan production by orbital fibroblasts, leading to classical manifestations of TAO. As we already discussed, the age, sex, and thyroid state preponderance of thyroid-associated ophthalmopathy. This case throws light on the rare presentation as in a young male of 25 years with eugenical status of the thyroid. Patients with thyroid abnormality should be screened and educated about the signs and symptoms. A multidisciplinary group including oculoplastic surgery, strabismus surgery, and neuroophthalmy can closely monitor patients for disease progression and implement appropriate medical and surgical therapy. Thank you.
Good evening. A rare case of retinochoroiditis with unique presentation. So coming to the case history, 21-year-old healthy male presented with acute painful blurring of vision in right eye since 3 weeks with no associated features. Gender, systemic and external ocular examination were normal. Visual acuity best corrected was hand movements on right eye and 60 spots on left eye. Color vision and contrast sensitivity right eye we could not assess, left eye it was normal. Anterior segment findings of right eye shows mild conjunctival congestion and 2+ cells in the anterior chamber. And the posterior segment of the right eye shows pale retina with dome-shaped elevation with blurred disc margin with edema, and there is an absent foveolar reflex. And left eye was normal. So our provisional diagnosis was posterior inflammatory disease right eye. We investigated this patient, CT brain and orbit was done, it was normal study. Complete blood count was within normal limit with an increased C-reactive protein of 52.7. B-scan show there is a thickening of the choroid with a T sign, and the OCT shows there is a complete distortion of the foveal contour with increased thickening of the retinal layers with subretinal fluid accumulation. Left eye was found to be normal. So our differential diagnosis include Wicked syndrome, serpiginous choroiditis, and posterior scleritis. So based on the investigation, we thought that could be probably a Wicked syndrome or posterior scleritis. We have given the patient oral steroids 1 milligram per kilogram per day and the topical steroids, cycloplegics for pain, and the calcium supplements. After 2 weeks of follow-up, what we have obtained is there is a clinical improvement in the right eye with an improvement in the vision 636 parts. But unfortunately in the left eye, the vision got dropped out and we can see multiple cystic fluid spaces in the left eye, and can be seen in the OCT also. So we have given posterior subtenon steroid injection in the left eye, and this is a story of the follow-up of this patient. So initially in the right eye, all the resolution of the edema happened, and there is a resolution of the edema with a scar formation in the perifoveal area, which is an improvement of visual outcome. But in left eye, which presented normally initially, which later presented with an exudative retinal detachment, and we have given the posterior subtenon injection, and we have seen that there is a scar formation in the macular area, which is resulting in the poor visual outcome in the patient to the 636 and not improving near vision. So we can see the same findings in the OCT also. So our take-home message is posterior segment disease present as unilateral can subsequently become bilateral also. It is challenging to derive at a single diagnosis. Unless diagnosed and treated early, it could cause sequelae. Based on the disease entity and the prognosis, the patient should be prepared accordingly. Thank you.
Good evening. My topic is case report of Golden Hair syndrome. Purpose to report a case of Golden Hair syndrome. Introduction. Golden Hair syndrome, oculovertebral dysplasia, is a rare congenital disease arising from the normal development of first and second branchial. Multifactorial etiology has been proposed where nutritional and environmental factors along with the genetic component have been projected as causative factors. Maternal diabetes, hypertension, malnutrition, drugs like thalidomide, cocaine, retinoic acid, chromosomal aberrations like 3 deletion, 6 deletion, deletion 18q, deletion 22q happens. Prevalence ranging from 1:3,500 to 1:7,000 live births. Male is to female ratio is 3:2. Case report. A 13-year-old male child came to the ophthalmology department with complaints of defective vision of left eye. On examination, visual acuity, right eye is 6'9", left eye it is C of 1 meter, and left eye is associated with severe ptosis. On anterior segment examination, limbal dermoid is present in the left eye. On general examination, preauricular tags were present on both ears. Fundus examination, both eye media clear, optic disc vessels normal, macula on, and FR present. This is the picture showing limbal dermoid, and the second picture shows us the preauricular tags. Discussion. Diagnosis of Golden Hair syndrome is based on clinical features. In eyes, we can see the epivalvular or limbal dermoid. Coloboma can be seen. Limbal dermoid occurs in 35% of cases, usually in infratemporal quadrant of limbus. In a ear, unilateral bilateral preauricular tags of skin of both skin and cartilage. Microtia, anotia, blind fistulas of the ears are seen. In the face, marked facial asymmetry with unilateral macrostomia. Hyperplasia of the mandibular ramus, hyperplasia of the zygomatic area may be seen. Skeletal structures, defects of the skull and spina bifida, hypoplastic, fused vertebra, hypoplastic vertebra, butterfly vertebra can be seen. Coming to conclusion, a multidisciplinary approach is necessary for overall well-being of the patient, and a treatment protocol should be determined as early as in the life as possible to avoid physical difficulty and psychological stigma to the growing child. Pediatric specialists along with the ENT, orthopedics, neurosurgeon, orthodontist and maxillofacial surgeon and ophthalmologist to decide on the most appropriate treatment plan, which varies with the age and systemic association. Thank you.
Myself, Dr. Bhuvaneshwari from Government Medical College, Kadapa. My poster topic is on upper and lower eyelid basal cell carcinoma, non-Mohs repair, a case report. Aim to report a case of both upper and lower eyelid basal cell carcinoma and its management. Introduction. Basal cell carcinoma is the most common and locally invasive eyelid malignancy. The most common location is the lower eyelid, typically presents between 5th and 8th decades of life with female preponderance. Risk factors include increased sun exposure, immune suppression and associated inherited predisposing conditions like Gorlin-Gall syndrome and Basic syndrome. Material and methods. A 65-year-old female presented to our OPD with mass in the left lower eyelid extending to the upper eyelid at the lateral canthus, which was insidious in onset and slowly progressive over years. On ocular examination, 2.7 into 1 centimeter pigmented nodulo-ulcerative mass with rolled out edges and well-defined margins along the left lower lid extending to the upper eyelid margin, where the cilia are absent over the involved part. Best corrected visual acuity is 6.6 in both eyes, and anterior segment and posterior segment findings are unremarkable in both eyes. Wedge biopsy showed islands and nests of basaloid epithelial cells in the dermis with peripheral palisading arrangement of cells suggestive of basal cell carcinoma. On radiological examination, CT and MRI orbit showed no local soft tissue invasion and bony invasion. Management includes, we did the wide excision with 4 mm clear margins of both upper and eyelids, and periosteal flap was taken to support the upper eyelid. Lower lid reconstruction done by sliding flap from temporal region. Postoperative period is uneventful, and these are the pictures showing excision. Results, excellent surgical outcome in terms of cosmesis and anatomical integrity. Conclusion is the gold standard treatment for basal cell carcinoma is wide excision of tumor with clear 4 mm margins with sliding flap, and there is no recurrence after 1 year of follow-up with aesthetically pleasing results. Thank you.